Good evening, friends, and welcome to the Thursday evening teaching session brought to you from Lokmanya Tilak Municipal Medical College, Sion, Mumbai. We are sorry for the delay today due to some technical issues. We will not be able to project the PPT, but the presenter, Dr. Sagardeep, will possibly just speak orally and present the case. And then we have the child for examination. So, Dr. Sagardeep.
Sorry, sir, for the technical glitches. Good evening. So we have 11 years, 4-month-old boy, third by birth order, born of second degree consanguineous marriage, hailing from UP, resident of Nalasopara, Muslim by religion and Khan by community, brought by parents and informed by parents as well, reliable, with the complaint of tingling sensation of bilateral lower limb and upper limb since the last 3 days, and difficulty in walking since the last 3 days. The child was apparently all right 3 days back. On 3rd May, he suddenly developed a tingling sensation of bilateral lower limb and upper limb on rising up from the sitting posture. Tingling occurred in both the limbs simultaneously. It was felt initially distally more. It progressed from the legs to the thighs at the same time, and within the next 10 to 15 minutes, the child also felt the tingling sensation in the upper limbs as well. The progression was from distal to proximal, from the legs to the thighs. The child also mentioned that he felt the tingling sensation in the trunk as well. He also had difficulty in walking since the past 3 days. It was felt more distally. The progression was from distal to proximal, from the legs to the thighs. He was unable to get up from the squatting position. He was unable to wear slippers. But he was able to use his hands for eating and comb his hairs as well. He is also able to feel the ground as well as clothes on his body. He is able to appreciate the modalities of temperature, hot and cold, pain, touch. And the patient feels that the weakness as well as the tingling sensation has improved during the past 4 to 5 days. It was associated with pain in the lower back. It was present continuously throughout the day. It worsened on getting up from the lying down position, bending down. But according to the child, the pain decreased. The pain decreased on walking, and as the day progressed, the child is able to tell when he has the urge to pass urine. There is no involuntary passage of urine, no urgency, no burning sensation while passing urine, no hesitancy, no poor stream or dribbling. There is no constipation and no fecal incontinence. There is also no history of any forgetting the recent events, then any convulsion, then headache, vomiting. There is no history of any delusion, hallucination, no difficulty in vision, hearing, blinking, closing eyes, swallowing food or water, or speaking. He can appreciate the modalities of taste as well. There is no deviation of the angle of mouth, no tightening or excessive loosening of the limbs. There is no involuntary movement as well. There is no history of fever, cough, cold, rash, loose stool, any recent vaccination, no similar episode in the past, no history of any khechri dal consumption, or no history of any dog bite. However, there is history of trivial trauma 15 days ago while riding bicycle. No medical consultation was taken at that time since no significant complaints followed this event. Past medical history, no history of any admission in the past, no history of any major childhood illness. So sorry, another history in the present illness is no family history of COX or COX contact, and no history of any significant weight loss. Birth and ANC history, spontaneous conception at the age of 30 years, registered pregnancy in 5th month, iron and folic acid injection tetanus tox were taken, ANC basically uncomplicated, delivered by normal vaginal delivery, full term, birth weight being 3 kg, cried immediately after birth, and no history of any NICU stay. Sir, in the immunization, his 10th year immunization is pending. Developmental history, safe goes to school studying in class 5 with average scholastic performance. Dietary history, mixed diet, he eats from the family pot. Total calorie intake is 2000, total calorie requirement is 2400, and his daily intake is 1900. His calorie requirement is 24 gram, and his intake is 20 gram. And the family history, so there are 4 siblings. Safe is third by birth order, 11 years 4 months. No family history of any paralytic disorder. So socioeconomic history, according to modified Kuppaswamy, they come in lower middle class.
Okay, so the first complaint is tingling in both lower limbs and upper limbs since last 3 days. So what is the interpretation? What is your thought process? Hold it close.
It may be any kind of peripheral neuropathy.
Okay, so first you want to say that the anatomy of this complaint is the nerves, right?
Okay.
Now you have to decide where are the nerves getting involved. So he said both lower limbs, both upper limbs, right? So is it a generalized peripheral neuropathy?
No, sir. No.
Why not?
generalized.
There can be a generalized peripheral neuropathy or there can't be. Any situation, any conditions, any thoughts?
Vitamin B12 deficiency.
B12 deficiency, anything else? What can cause a generalized problem? Systemic disease. Anything, which kind of a disease? Okay, diabetes. Then, so diabetes is an example of what? A metabolic problem or a toxin. So such things can cause a generalized neuropathy. But then of course the question is how acute, how sudden, at one go. So you'll have to think of all that. What else comes to your mind? So one is this group. Anything else? About the anatomy. So when can multiple nerves be involved? Yeah? Trauma. So, but trauma at multiple places is not possible, no?
If multiple intervertebral disc protrusion is there, if in case.
Okay, multiple intervertebral disc protrusion, no. So how you would have said that that is unlikely, multiple trauma is unlikely. But you would have said that all nerves originate from the spinal cord. So if it is a sudden pathology affecting the spinal cord or the nerves exiting from the spinal cord, then that is a possibility that so many nerves get involved at one go, right?
Is there any possibility that the central, anything in the central? For example, you have different kinds of involvement of peripheral nerves and center. ADEM, for example. Can it be like that? Should we keep that in mind? If not, why not? There is peripheral involvement. If there was any central involvement, is it likely to occur? Can we wait for that?
So that is possible. Sometimes you get them dissociated in time. So what is enkephalon and myelin involvement can be dissociated in time. So that is possible. So sir is saying, can it occur? That we don't know. But just now there is no central involvement, right?
Also very symmetrical with ADEM. ADEM is often patchy and discrete disease. Very central symmetrical involvement in ADEM is less likely. But we are thinking on a broader scale what can affect and produce this. So trauma and a generalized disease, spine, entire spine less likely, peripheral nerves, higher centers less. Can it be aura of a epileptic disorder? Sensory epilepsy, aura of a disorder?
Sir, aura will last for some time and it is followed.
Hold it close.
Sir, aura is temporary, but chronic symptom may not be.
But after the aura, he didn't get seizure. He will get it after 2 months. He may get it after 2 months. Aura occurs in a generalized seizure disorder or a localized disorder. Aura often tells you where the epileptic focus is coming from. So can it be generalized? Can there be a generalized epileptic disorder? Usually with aura, a generalized involvement in all may not be there. Maybe one hand tingling numbness followed by weakness and a generalized disorder, or it may just stop. Such a generalized disorder, we are entertaining higher centers in addition to peripheral nerves.
I think the first thing I want to know that what did the parents say or the child say? How did they say tingling numbness?
So in Hindi they told moongi jaisa.
So what did they say? You are interpreting tingling numbness. I want to know how does a layman says tingling numbness?
Pin and prick like. Or
Sir, he is saying they said mungi jaisa aaya. That's what they said, right?
Yes, sir.
Okay.
So that's what tingling numbness meant. The next question should have been, is there any positive movements?
No, sir, no.
So we want to go systematically. Okay. We want to be sure that there is no positive movements. I don't think a spinal cord comes into play. Because
So actually see the history mein you said the tingling was distal to proximal. That is a funny history. I don't know if we'll get such a history. And then you did not give us the time. You did say that there was difficulty in walking after that. But you didn't give us the timetable from the tingling to the difficulty in walking. As in, all neurological cases, you should present literally, as a chronology, as a story. So morning is started with tingling, by afternoon this happened, by evening this happened, next day morning this happened. It should come like that as a story, right? So we didn't get that association also of the weakness.
Also, you mentioned that the weakness was distal first and proximal.
Yes, sir.
That is your interpretation. What did the parents say? Will the parent be able to say that पहले distal weakness था?
So they told
Would
कि
one
how
of
did
you
you
ask
elicit
the
that
history? You take the history loudly. We want to know correctly how you take the history also and what is the correct history. Okay, would you try that? Doesn't matter. Okay, he speaks Hindi, both of them. Okay, डॉक्टर साहब बोलते हैं ना, पूछते हैं जरा बताना, क्योंकि हमें जानना चाहिए कि बराबर क्या होता है, ठीक है?
बेटा आपका नाम क्या है?
सैफ खान।
सैफ खान। आप कितने उम्र है आपका?
11 साल 4 महीना।
अच्छा, आपको क्या हुआ था, आप कुछ बताओगे?
यस।
क्या हुआ था बताओगे?
मैं दोपहर में खेल के आया था।
कौन सी तारीख है ये?
ये
3 तारीख को।
हाँ।
क्या हुआ था?
मैं दोपहर में खेल के आया था, तब खाना खा के बैठा, तब बाहर अप्पी कुछ कर रही थी, स्टोन चिपका रही थी, तब बैठ के मैं देख रहा था, तब मेरे पैर में अचानक से मूंगी आई, तब मैं थोड़ी देर के लिए चली गई, तब फिर से आ गई धीरे धीरे, तब मैं खड़ा हो रहा था, तब गिर पड़ रहा था, 10-15 मिनट के बाद पूरा शरीर में होने लगा।
तो जब पहली बार आई थी वो कितने देर के लिए थी?
हाँ, पता नहीं।
और ये आपने किसी को बताया इसके बारे में?
मम्मी को पता है।
उस टाइम पे क्या हो रहा था, मतलब मूंगी आ रही थी, मतलब
झुंझुनाहट से ऐसे हो रहा था।
सिर्फ पैरों में था कि और भी कहाँ पर था?
पहले शुरुआत में पैर में था।
और फिर उसके बाद कितने देर के बाद वो ऊपर आने लग गया?
10-15 मिनट के बाद ऊपर आने लगा।
अच्छा, तो फिर उसके बाद?
तब मैं खड़े नहीं हो पा रहा था, खड़े हो रहा था गिर पड़ रहा था।
अच्छा, तो ये आप दोपहर को ये आपने किया था।
हाँ।
तो ये कितने देर में ये पूरी चीज़ हो गई थी?
10 या 15 मिनट।
10-15 मिनट में आप गिरने लग रहे थे।
हाँ।
अच्छा, तो उस टाइम पे और भी कोई था आपके साथ?
हाँ, मम्मी थी, अप्पे थे।
अच्छा, तो उन्होंने कुछ आपको बताया उसके बारे में? आपने क्या किया उसके बाद?
उसके बाद गिरा था, तब मैं घर पे बैठा था।
वो खुद से चले गया कि आपको कुछ करना पड़ा उसके लिए?
नहीं, अपने आप चला गया था, फिर से आ गया था।
कितने देर के बाद फिर से आया?
5-10 मिनट के बाद आया।
उसी तरह से नीचे से शुरू हुआ था?
नहीं, यहाँ इतना से अचानक से फिर से यहाँ पकड़ा था।
अच्छा, उसके साथ और भी कुछ हुआ था साथ में? कुछ दुख रहा था, ऐसा कुछ हुआ था?
यहाँ पर दुख रहा था पीछे।
अच्छा, और क्या हुआ था उस टाइम पर?
और कुछ नहीं।
कुछ चक्कर आ रहा था,
नहीं।
सिर दुख रहा था, सांस लेने में दिक्कत हो रही थी?
नहीं।
ऐसा कुछ नहीं। ये फिर उसके बाद क्या हुआ?
उसके बाद मैं खड़े हो रहा था, गिर पड़ रहा था, तब मम्मी बोली सो जा, तब सो नहीं रहा था, नींद ही नहीं आ रही थी।
तो ये 2 बार हुआ है। उसके बाद आप इधर आ गए थे?
हाँ।
ओके। वो जो मूंगी आ रही थी,
हाँ।
वो दोनों पैरों में थी
दोनों
कि
पैर में।
एक ही पैर में थी?
दोनों।
अच्छा।
So see, we've always discussed that why do we take a history? We want to come to the root of the problem. So the first thing that you got to know is that he said it started with tingling and then he couldn't stand, right? So now it happened within 15 minutes of that. So now you have to first further explore whether there was anything else that was there with that, as in how was his hands, was he able to sit in bed, was he having any higher, because you want to try and decide the anatomy of this problem, right? So that is the first step as a next question in the history. So do you think his hands were involved? Did you get that at that time?
No, I didn't
Ask.
तो जब आपको उस टाइम पे जब मूंगी आ रही थी, उस टाइम पे आपके हाथ कैसे थे?
हाथ वैसे ही थे, उसमें भी हो रहे थे।
उसमें भी हो रही थी?
हाँ।
मतलब हाथ आप कुछ पकड़ पा रहे थे?
नहीं।
मतलब हाथ ढीला हो गया था, कैसे हुआ था? हाथ कैसा था हाथ?
ये वाला हाथ से कुछ नहीं कर पा रहा था, ज़्यादा कुछ नहीं कर पा रहा था।
और ये हाथ से आप?
ये वाला सही था।
अच्छा।
उसमें मूंगी थी।
ओके, सिर्फ एक ही हाथ, सिर्फ राइट हाथ में थी। और उस टाइम पे आपको कुछ चक्कर आ रहा था, ऐसा आपको कुछ बेहोश जैसा लग रहा था, सिर दुख रहा था?
नहीं।
ऐसा कुछ नहीं था सर। इट वाज अकॉर्डिंग टू द चाइल्ड, इट वाज ओनली द राइट लिम्ब, राइट अपर लिम्ब which was like he could not move, he could not use his right upper limb, but there was no central signs in
So
it always remained to right side, or it came to left side? Because if it came to left side within some time, then it's almost starting simultaneous. So बायां हाथ के बाद दाहिना हाथ में पहुंचा क्या? टिंगलिंग, वो झुंझुनाहट थी?
वो झुंझुनाहट ये हाथ में आई कि नहीं आई?
दोनों साथ में आए थे।
तो कितने देर के बाद? पहले इसमें आई थी?
नहीं, दोनों साथ में।
दोनों साथ में आई थी।
नहीं, लेकिन कमजोरी ये हाथ में थी ना।
हाँ।
तुम बोला ये हाथ से कुछ कर नहीं सक रहा था, ये हाथ से कर सक रहा था, फिर बाद में ये हाथ कमजोर हुआ कि ये कमजोरी नहीं हुआ?
ये कुछ नहीं हुआ, वैसे ही है।
वैसा ही अच्छा है ये हाथ।
हाँ।
और ये हाथ कमजोर हो गया था?
अभी सही है।
अभी सही है, लेकिन
वो
तभी
time पे-
कमजोर हो गया था।
हाँ।
So he had weakness in his right
Right
upper
upper
limb, but not in his left. He had tingling in both.
Both.
And all this happened within
10
a very short time of each other, right? And no central symptoms. So now what are your initial thoughts based on this as to where is the anatomy of the problem?
Sir, it looks like a lower motor neuron,
Okay.
and in lower motor neuron it looks like a nerve or a nerve root. Then we'll have to see.
Why nerve root?
Sir, it was associated with there's a history of pain.
Pain where?
आपको अब ये सब हो रहा था तो आपको कुछ कहाँ पे पीठ में दुख रहा था? और
पेट में नहीं, इधर साइड, इस साइड।
और कहाँ कहाँ पे दुख रहा था?
और उस वहीं पर।
और ये कितने देर के बाद दुखना शुरू हुआ है?
उसी टाइम से।
तो जब
यहाँ पर पहुँचा था धीरे धीरे, तब दुखना स्टार्ट हुआ था।
और ये जब भी आपको झुंझुनाहट हुआ है तब आपको ये दुखा है क्या?
हाँ।
और उसके बाद वो दुखना का क्या हुआ? वो खुद से चले गया?
अभी नहीं है, इधर पे है।
अभी भी पीछे है?
अभी इधर है।
तो वो पेन मतलब बहुत ज़्यादा था, थोड़ा था, कैसा था?
ज़्यादा था।
आप कुछ कर पा रहे थे वो टाइम पे कि कुछ भी नहीं कर पा रहे थे?
नहीं, बैठा था सिर्फ चुपचाप।
और वो उसके क्या हुआ? वो खुद से चले गया? वो जो दुख रहा था वो खुद से चले गया? कुछ आपको दवाई लेनी पड़ी? क्या किया आपने उसके लिए?
उस टाइम दवा नहीं लिया था।
खुद से चले गया?
हाँ।
कितने देर में चले गया?
गया नहीं था।
अच्छा, था वैसे ही था?
हाँ।
The idea of asking this question was the pain was peripheral or mainly in the spine or related to spine, because when we talk of peripheral nerves you also have roots in mind, and if the roots are, because pain is not a feature of peripheral nerves, but is a feature of radiculitis, and then you will get pain especially which is producing spasm of the paraspinal muscles. So the pain is mainly here, and that's what he said. So trying to localize apart from the peripheral nerves directly to the roots. Could you, आप खड़े रह सकते थे उस टाइम?
नहीं।
चल भी नहीं सकता था?
नहीं।
लेकिन अगर लेटे हुए थे तो बैठ सकते थे? ऐसे लेटे हुए तो बैठ सकते थे?
नहीं।
तभी तू बैठा था कि लेटा था?
बैठा था।
बैठा था। तो ऐसे बैठे में हाथ ऊपर कर सक रहा था ये?
नहीं।
नहीं।
ये वाला नहीं हो रहा था, ये वाला हो रहा था।
अच्छा, लेकिन बैठा था तो गिर नहीं गया ना, बैठा रहा?
हाँ, ऐसा लग रहा था इस साइड, ऐसा ऐसा गिरने वाला था।
गिरने वाला है, बैठे बैठे भी गिरने वाला ऐसा लग रहा था?
चक्कर आती थी इसके लिए गिरने वाला था कि जैसे शक्ति नहीं है इसके लिए गिरने वाला?
पता नहीं।
Yeah, pata nahi, but probably truncal weakness also along with all this at that time. Yeah. तभी पेशाब में कोई तकलीफ था?
नहीं।
अच्छा, पेशाब हमेशा बरोबर कर पा रहा है, तब ये हुआ तब
हाँ।
से? ऐसा नहीं है कि पता नहीं चलता है निकल जाता है, ऐसा कुछ भी नहीं है?
नहीं।
नहीं ना, ठीक है। अभी 3 तारीख को ये हुआ ना?
हाँ।
अभी पिछले 8 दिन में ये बढ़ते गया कि जैसा है वैसा ही है कि अभी ठीक हो गया?
अभी ठीक हुआ है, ऊपर हुआ है, यहाँ पर।
ऊपर दुखता है?
हाँ।
और ये हाथ में ताकत आ गया?
हाँ।
और पाँव में भी ताकत आ गया?
हाँ।
कितने दिन के बाद आया ताकत?
यहाँ पर आया तब थोड़े दिन के बाद।
यहाँ पे आया उसके बाद ताकत आया?
हाँ।
5th. So 3rd it started, 5th he got admitted here.
तो जो आपको जो फर्क पड़ रहा है, अच्छा लग रहा है, वो इधर आने के बाद हुआ या उसके पहले ही थोड़ा थोड़ा पावर आने लगे था, शक्ति
इधर
आने
पे
लगी? इधर आने के बाद शुरू हुआ?
हाँ।
वो भी कुछ दवा देने के बाद हुआ कि अपने आप ही हुआ?
दवा देने।
So now what do you all make out of all this history? So first tell me, means one reason for, or one or more than one reason why it is not central.
At the time of event, मतलब child is conscious. First thing is higher mental functions seems to be normal, cortical functions. Then
Can it be bilateral central? There is some interpretation of sensations here also. So it is bilateral thalamus, central, bilateral.
but in history, sir said that मतलब if thalamic involvement is there, the child could perceive a hot, cold, light temperature sensation is still intact.
We don't know that.
No, see, we have to have more solid reasons. So when you said that he was conscious, so do all central problems have to lose consciousness?
No, it's not like that.
So why in him? What you say is in fact the correct answer. But correlate and tell me why in him the fact that he was conscious makes it not central. All central problems need not lose consciousness, right? His problem is unilateral or bilateral?
Bilateral.
So see, if it is central, one hemisphere affected or both affected?
One hemisphere.
Both hemisphere affected. With both hemisphere affected, you can't be totally conscious. That is why the point that he doesn't have any central complaints is important, and you can't have two focal lesions both on either side, both suddenly at one time. That is why this is not central. You got it?
Yes.
Okay.
Again, if it's a thalamus, then all kinds of sensations are reaching there. It's not only one type of sensation. So posterior column sensations, okay, lateral. So you need to ask, he was asking whether he could sit stably. Looks like yes, mostly, though he said that he was little unstable, maybe, but he had no evidence of a posterior column affection, because that thalamus would have got all, and they could have been dissociated also, okay, because the tracks cross at different levels. So again, we would have had some differential points. So I think what we understand now is that there was also some weakness, and there was also some tingling numbness and also pain. Now we have to put all this together. Now the lesion may not be just peripheral now, therefore we go back, and he's pointing out to the back. So possibly the radiculopathy. Now when there is the radiculopathy, there could be some evidence of a myelopathy or a neuropathy, because all the tracks are similar, and therefore we know that this is more likely a radiculoneuropathy rather than isolated peripheral neuropathy or isolated radiculopathy. So I think this is where we stand just now, right? Okay. So can somebody examine quickly as is there?
Acute onset, quickly progressive, and perhaps responding to the treatment that is given.
Sir, he only told pain in the lower back, sir, nothing like radiation to the thigh or around the legs. He was mainly, sir, pointing towards the pain in the lower back and in the scapular area.
Central or peripheral on the back? More central
Sir, central. Sir,
So paraspinal.
What is the etiology of this according to you? Pathology and etiology? Just thinking.
sir, compressive myelopathy. Sir, compressive myelopathy, like it could be extradural, extramedullary, extradural, for example, like it could be a port spine or any abscess or fracture which can compress the nerve root and cause a tingling, numbness and radicular pain.
So what are your thoughts on this? Whether it's a compression?
Progression is very quick for it to be a...
So how does a compression progress? So take two examples. Take the example of a vertebral fracture and take the example of a SOL in the spinal cord. How will these two compressions progress?
SOL, the fracture will be very fast in progression and SOL will be slightly slow in comparison to the fracture.
Slightly slow means how slow? Or can it be in this kind of a progression?
No, sir. Months to years.
So this is reasonably acute. So compression is, by definition, it is not that acute. And if it is acute, then the event which is causing the compression is very obvious, like a huge injury or some such thing.
And any spinal cord compression, always asymmetrical. Which is that compression which is pressing everything equally? Never. So it's always asymmetrical to start with and will become involved on the other side. Either side involved in the initial stage equally is unlikely. And of course, apart from that, the involvement of bladder, bowel, etc.
And I think any acute onset issues are either physical, traumatic, vascular, immune mediated, allergic, okay, so largely, and metabolic. So we have to fit in one of these: metabolic, immune mediated or allergic, vascular or physical, that is trauma. Now here trauma is out. Now the question is, could it be metabolic, immune mediated or a vascular? If it is a vascular, again it's usually localized to the vessel involved, whatever the cause. So this is not vascular also. So now there remains immunological or metabolic. Okay. So acute onset in this child has to be metabolic or immune. Now add further, quickly recovering. Okay. Now which one quickly recovers out of these two?
Metabolic.
Metabolic. Immune may also be. Okay, if you thought that IVIG or a steroid, okay, could improve as well. But you are right. The improvement is fast. And he said on 5th he came and started improving. So improvement looked very fast. So the question is, could it be metabolic? Now what is metabolic? It includes the toxins, it includes the poisonings,
Vitamins.
whatever. Okay, it doesn't mean that it's only the electrolytes or whatever. So you have that group in question. Okay, though if you are lucky and immunological disorder has suddenly come in control, you may not rule it out, but in a day or two, quick recovery looks more like a metabolic. But what metabolic that, and what did you do to get rid of that toxin or something? Not so easy either. So that puts up to say, was it some naturally remitting issues? Okay. So we start looking at all these problems. Generally, acute immunological will take some time, but acute metabolic, unless it was something that you could immediately take care of, like hypocalcemia, you can quickly take care of, hyponatremia, hypokalemia, acidosis, okay, you can take care of it. But none of them will just produce such kind of a thing. And then if you look at the toxin, any poisoning, then it cannot just get out of it quickly. So we are not very sure about what the etiology was, and was it really the steroids or whatever that worked was. So we keep options on that, right? All right.
Come, we'll just, yeah, you want to ask them?
Would somebody come and take the reflexes and show quickly what it is?
First, let's start with the gate. So,
And what were the signs on the day of admission?
he was
now
not.
he is, huh?
हाँ. चप्पल निकालेगा बेटा? हाँ? Come on, what did you observe?
Broad-based gait.
Hmm?
Broad-based gait with
Broad-based.
short lift up.
Short lift up means?
The stance is short. I mean,
Okay. Short steps. Okay. Then what else? Come on, everyone. What did you observe?
Little cautious while walking.
Cautious while walking. What else? So what about the strike? How was his strike? Was it a heel strike? So only he was walking like this?
no.
Was he walking like this? So was he striking like this, like this, like this? No. So what was he doing? His foot was flat. So he was walking like this. It was not heel strike. Okay? So short steps, nor toe walking, but short steps and flat means what? Come on, it has to mean something. So when do I do this and when can I not do this? And I have to walk like this. Come on. So there has to be some weakness of the dorsiflexion at the ankle. That is a possibility. So you will reconfirm that on examination. Right? Okay.
Also, he was limping a little bit, if you noticed. What does that tell you? Asymmetry. There was some asymmetry between the two sides as far as he was walking very cautiously. And that leg on which he was limping, that was more flattish than the other one, which was slightly better. The other, if you saw, there was never like this, but there was a little heel touching. But other one where there was weakness, it was more flattish than that. So asymmetrical. Slightly asymmetrical, not much.
And what about the arm swing? Was it a good swing or a very minimal swing? So not a good swing. Very, means he was holding it close to, just in the plane of his body, right? Okay. So that was about the gait. Now come, someone do the motor examination. Come. Yeah, we have the cot. Do you have a bed sheet?
ऐसे चलो बेटा.
See how he is walking now. See. अच्छा बस अभी ऐसा चलो. See a little difference, symmetry. Yeah, thank you. एक मिनट पैर देखना है, इधर आ जाओ. हम पैर चेक करेगा. ओके, पैर में कितनी ताकत है अभी देखेगा. हाँ, जरा ऊपर आओ जाओ.
Sir reminded us when you take the jade, this is always necessary. पहले जाके आओ, observe everything, whether the heel is touching, what is touching first, is he limping, how is he turning, whether hand swing. Then ask him to do toe walking. So if he has a weakness of dorsiflexors, he can't do toe walking. Then ask him to do walk like this on the heel. So toe walking, heel walking. Then ask him to do what is known as tandem gait. That means heel to, this is for ataxia or latent ataxia. So all these 4 to 5 things, then ask him to turn. All these 4-5 things must come together, and then maybe you ask him to sit down and get up. That tells you the power of the glutea and other things. If you have done this, your physical examination of the lower limb is over in just 1 minute. Okay, but provided you test all the different elements of dorsiflexors, plantar factors, ataxia. Okay?
Come, one more person, come. Go up there, yeah. Shall you speak about the motor system, whatever you are examining, quickly tell us.
Sir, on inspection, there is no visible wasting of the muscle. There is no atrophy, hypertrophy. Posture is normal. On palpation, the feel of the muscle is firm. Active tone. So tone is normal in all the 4 limbs. Power.
So, in upper limbs, where is the tone first affected, or where is it best to check the tone? Or which pop joint and which movement is the most sensitive to pick up tone?
The distal joint.
Which movement?
Wrist. So for passive tone, we can just move the wrist and assess the tone.
So pronation and supination at the wrist is something which you should check. In lower limbs?
Ankle.
Abduction and adduction at the hip.
joint.
Okay, fine. Now, secondly, you checked tone, but in this child, you're not expecting spasticity. But spasticity is dash.
Upper motor neuron.
Velocity dependent. So, you have to check fast movement also to look for spasticity. Okay, go on.
So power. सीधा उठाना है ऐसे, उठाओ, जैसे क्या था, उठाओ सीधा, नीचे करो, सीधा उठाओ, नीचे करो, shoulder flexion and extension as a normal power.
At which joint?
So shoulder joint, abduction and adduction. हाथ को ऊपर उठाना है, सीधा उठाओ, नीचे लो, so shoulder abduction and adduction also the normal power.
Offer resistance. Don't hold it there only. You try to prevent him from movement and then see whether he can do it even against the resistance.
Means visually we got a feeling that you are applying very mild resistance. So it was like 4 minus types which we got a feeling. Okay? Okay. Lower limbs or elbow you want to do?
ऐसे करना है, ऐसे करो, इस पैर को करो ऐसे, पैर को ऊपर उठाओ ऐसे, करो, ऊपर उठाओ, ऊपर उठाओ, 4/5. Now it has improved, sir, but on presentation his plantar flexor and dorsiflexors were weak.
Okay.
Even now, what you saw was a good resistance for dorsiflexors, plantar flexor. There was a difference between even now. Yeah.
Reflexes?
पैर पूरा ढीला छोड़ दो, छोड़ दो, पूरा ढीला कर दो, so it is brisk bilaterally 3+.
Okay. Look at the ankle jerk and look at the plantars. So since the reflexes are brisk, you want to check in the upper limbs?
Yes, sir.
Check.
Want to check clonus?
Very good.
Other side.
Well sustained clonus, sir.
he was checking the tone, there was a suggestion that there was a clasp knife. Okay. Okay, very minimal, but there was a suggestion.
But to an observer, it does give an impression that
At the end of that, it could be just grade 1 kind of a thing.
should have been there at the onset of them. ढीला रखो भैया.
My suggestion of a grade 1 at the end of the
Yes.
program, but when he was doing it, it was obvious that there was some clasp knife coming up. Planter?
Two plus.
Planters.
Dorsiflexions extensor.
Why do you use the key?
Knocks. Pain.
Should give a painful stimulus to check plantar. What will be the response to a painful stimulus?
Withdrawal response.
So then where is the checking of plantar? Should never give a painful stimulus. So your stimulus shouldn't ever pain. So all this key and all can be actually painful. Now, where have we learnt all this from wrongly, and why have we learnt it? Because when we go to the adult wards as students, and those adult patients have very thick soles which don't feel anything, so that is why we have started using all this and the pointed end of the this hammer and all that. But that's not right, right? So in children you should not be using all this. You could even do it with this blunt side of the thing, right? Okay, you have to stroke the sole. What is written in the book? Stroke the sole on its lateral aspect. Is this stroking or poking? Right?
Axial.
So first you don't check power of axial muscles. How will you check?
We'll ask the patient to rise up from the supine position.
I don't know if you have to use resistance here. The very fact that he can get up is good enough, I
You
think.
can put here for neck muscle, but he is able to do. You may have to do it in prone position. Ask him to raise the head. Okay. Anything else you would like to do? Okay. What else? What else?
So besides sensory and motor, what else can be involved is what sir is asking.
So spine examination.
Exactly what do you want to do? Want to elicit radicular pain. How will you do that?
So straight leg raising test.
Would
Do
you
it.
like to do that? Surprisingly normal.
He's treated,
He's
so
treated.
it's already.
Never forget SLR in Guillain-Barré syndrome.
Come, so now interpret your findings.
Sir, he has got Rombach's test also positive. So we did in the ward, so we found one.
Sure.
Don't touch it. All right. This should happen to us also.
So if Romberg's is positive, what does it suggest?
Posterior column lesion.
So posterior column in the substance of the spinal cord.
Yes, sir.
So here are you expecting that kind of a lesion?
No.
So it would have been surprising if Romberg's would have been positive here. It would mean that the pathology is going beyond the nerve roots, which is little unusual. Yeah. So how will you analyze your findings?
So 11 years, 4-month old boy, but then developmentally normal. Case of ascending paraparesis, distal more than proximal, with sensory involvement in the form of tingling, without cranial nerve involvement, without bowel and bladder involvement, anatomical localization being at thoracic level, to rule out transverse myelitis, Pott's spine, and
Okay, so why transverse myelitis and why Pott's spine?
so progressive weakness along with sensory disturbances, history of lower back pain, preceding trivial trauma.
No, so transverse myelitis, what are your big points that you want in transverse myelitis? Transverse myelitis is at a level, no? So did you get a level?
No.
You're saying something? And yeah.
What else?
He initially told you that it was asymmetrical. He said his left hand was not affected in terms of power, but his right hand was. You think that would happen in transverse myelitis?
No, sir.
So your initial story is not like transverse myelitis, right?
And what else?
And when you talk of sensory disturbances in transverse myelitis,
Pain.
what kind of sensory disturbances?
Pain, touch.
Yeah, so crude touch, pain, temperature, all gone below a certain level. So this is not that kind of sensory disturbance. hyperesthesia at the level of the lesion.
And
So
what
this-
about sphincters?
Sphincter disturbances can be there. He doesn't.
Okay, so there are many points against transverse myelitis. What about port spine? Anybody wants to discuss for or against?
Sir, rapid progression, radicular pain, ascending weakness, being extramedullary, late bladder and bowel involvement.
So again, port spine wouldn't start with tingling, which is a symptom of a nerve root or a nerve involvement. So that's very unusual for port spine, and that too in bilateral and in so many areas. It has to start on one side.
That could be surname, metabolic neuropathy,
Such as?
vitamin B12 deficiency causing subacute combined degeneration.
Can it be your post-infectious polyneuritis? GPS?
So our GBS ascending areflexic motor paralysis. So areflexic, but his reflexes are brisk, more of upper motor neuron type of features.
Yeah, so what all did you get to favor upper motor neuron
So
besides the reflexes?
So clonus present,
Okay.
reflexes brisk, superficial reflexes absent. Plantaris extensor. Spasticity is some form of grade 1.
Okay.
So no wasting visible, no atrophy.
So that is in against what or in favor of what?
So this is in favor of upper motor, doesn't go for lower motor.
But do GPS have wasting?
No, sir.
So wasting is seen in anterior horn cell disease or very long standing muscle disease. Otherwise you don't get wasting. So absence of wasting doesn't take you away from.
I think to begin with, on the history, we thought that it was going to be a lower motor neuron lesion, tingling, numbness, weakness, etc. And we are reasonably okay. On seeing the weight, we realized that it was not very symmetrical. There was some asymmetry. Okay, so a typical peripheral bilateral neuropathy or radiculoneuropathy would have been nearly symmetrical. So the first issue that we picked up on gait was there was some asymmetry and there was some pain also, limping as well. Okay, so asymmetry would put us to say whether there is something else happening. Then on examination we got an upper motor neuron lesion, bilateral. Okay, much more in the favor of plantar extensor and a clonus, a suspicious clasp knife. Okay, but we are seeing a recovering patient now. So the power has recovered, the tone is also near normal, there is no typical clasp knife as of now, and the clonus and the plantar extensor persist, which means that the power has improved, but the lesion is still evident. So now if we put upper motor neuron lesion bilaterally, okay, upper limb just now looks okay. We don't know what it was right to begin with, okay, but we had an asymmetry there also. That right arm was weak, but the left arm was not weak. So if that was so, then should we go way up there? And now he is recovering, so we don't have exactly the level anywhere, etc. The transverse myelitis looks unlikely. Again, it's symmetrical. So the question is, what else you have an issue about it? He also complained of some paraspinal thing. So there was some inflammatory lesion, maybe traumatic. Okay, trauma is also an inflammation. So whether there was some traumatic lesion and that started all of a sudden. We said started all of a sudden, but initially we are looking at bilateral lower limbs, distal, so we are talking about peripheral. But now looking at that's kind of a story, upper limb definitely, both lower limbs involved as far as symptoms were concerned, but the weakness was one. So asymmetrical problem which is likely to happen. Now, why should such a thing happen at all? Now obviously if it's an extradural, it could happen suddenly, and suddenly it happened without reason, so there possibly whether there was an unnoticed trauma. Okay, now we go one step further. If the trauma was unnoticed but the manifestations were quite severe, then do you have anything abnormal there that a trivial trauma has caused much more disproportionate damage? Okay, so what can that give? I'm looking at trauma is not obvious. Now, you don't have a trivial trauma and then suddenly all those things coming up. So trivial trauma and a lot of problems coming up, let's call it some pathological trauma. Okay, trauma has been just an excuse to worsen. What kind of pathology? Generalized bone pathology? Okay, like any vitamin D deficiency, osteoporosis, whatever. Okay, or a localized one. The localized one also would include some localized malformation like any cyst there or whatever. Or even at times disease like leukemia, for example, is a bone marrow problem. This doesn't look like that because the story would have run. So I think we are left with, on a clinical issue, an acute onset, asymmetrical, spinal lesion. Okay, more than just a peripheral lesion. So there was tingling and numbness, which also means that there were sensory nerves also were involved. Now, we cannot explain all that with what happened with one limb and other, both the lower limbs. So we are seeing something that has improved now, but let's imagine that there was reasonably an asymmetrical involvement of both lower and upper limbs, and we don't know what happened in between, whether there was the reflexes or the superficial reflexes were present or absent, which might give us an idea whether we are really at a lower as well as an upper. So at this point of time I am not able to put anything on a particular etiology. Okay, the fact that he has recovered, whether it was some trivial trauma that has recovered, and was there any, it obviously is not a hematoma. An extradural hematoma would be disastrous. Intradural, these subdural hematoma can go on very slowly, so that's also not likely. Could it be a vasculitis of any kind? Unusual. Okay, vasculitis would not be so at multiple levels. So really we are, at this point of time, I'm not sure where we are. All that we know is that there is an upper motor and also on the history like a lower motor, because tingling numbness is there. So let's call it as a myeloradiculoneuropathy. Okay, that's the anatomy. Okay, radiculo is possibly based on again our history, okay, of pain, neuropathy based on our tingling numbness, and the myelopathy based on our upper motor neuron lesion. So we'll call it as an acute onset myeloradiculoneuropathy, quite disseminated. So not at one point. Now if it's a radiculopathy, then it has to be disseminated involving upper limb, lower limb, etc. So it's not at one point. So that's where we stand. And he has recovered quickly. Now you could also give me the history. What did we do to recover him?
Sir, as of now, sir, we have kept the patient on supplements, vitamin B12 supplements. So, sir, his MRI spine, sir, we have done an MRI for him. So, sir, it shows long segment, ill-defined, non-enhancing T2 hyperintense signal in dorsal spinal cord, extending from C6 to D3, D4 level for an approximate length of 5.6 centimeter, giving inverted V sign. These features are suggestive of subacute combined degeneration of the spinal cord more than transverse myelitis. We have sent some vitamin B12. It's awaited, and sir, interestingly, sir, the CBC was sent after the supplements, and also the indices are on the low, matlab normal range, sir.
Could the indices be normal for any other reason? Dimorphic, no? So there will be a little bit of a offsetting of the micro and macro. So how would you then pick up whether it is iron deficiency or no, along with B12?
He has hyperpigmentation of the knuckles.
He has. Yeah, so iron, then you might have to do serum iron studies to prove that he is simultaneously iron deficient also.
How much B12 did you give parenterally, and within how much time he improved?
For oral supplementation only.
Actually, B12 oral doesn't even improve, and parenteral also, it takes time. And parenteral therapy goes on maybe alternate days for a week or 2 weeks, then maybe twice a week, once a week. The whole story goes on for a long time. Okay. Of course, today you know that B12 is available even as a nasal one. Okay. So you can avoid injectable and you can use a high concentration nasal B12. But it takes time.
If you give B12 today, tomorrow your CBC will become normal.
No. Which deficiency can get well within just 2-3 days? Deficiency. Okay. Vitamin C. You give 500 milligram, in next 2-3 days the fellow starts running. He was not even able to stand or walk or pain. But barring that, all other vitamin A and B and rest of them take a lot of time to improve. So again, we are not sure. We know that there is, yes, B12 deficiency. Some of these things, as you rightly said, we haven't much seen subacute combined degeneration, so we have no experience of that. But we only said that we have a myeloradiculoneuropathy. Okay. And I think going retrospectively back, a quickly recovering makes it little difficult to understand that it was just deficiency. Okay, because deficiency can't just improve quickly. And now you say you gave orally. Okay, orally is a drop in the ocean. So that must not have been. So did he recover on his own? Now how can he recover on his own? So we really don't know. And which means possibly that he has not recovered. Okay, and obviously signs are still persisting. His walk is also not normal. He is still having some mild weakness. So whether his weakness has partly improved, we really don't know that. What have your neurologists talked about?
He's like from first day still same only. Like by the way we have observed in ward, has not like improvement to nahi dikh raha hai, same ही है sir.
What did she say?
But when he came, was he bad?
Oh, so there is no improvement.
So when he came, from that time only this much is his power.
But history-wise, he was unable to walk, he was unable to stand.
Yeah.
History-wise, he has improved and he was worse than that, at
He
least
was
at
worse
onset.
than that, sir. Actually, sir, we have put him on for neuropathic pains, gabapentin and all. So his pain has decreased. Initially, it was all the way more, and power is also sort of power is also improved, if not significantly.
Also, at
it's
the
improved.
onset, you said second-degree consanguinity. What do you mean? What is second-degree consanguinity?
He feels पहले से काफी अच्छा है.
So with cousins and all.
Cousins is second-degree consanguinity. What is first-degree consanguinity?
First degree with near one, I mean own brother or own.
Yeah, brother, father, daughter, mother, son, maybe brother. First degree. Second degree,
Uncles and
uncle, niece.
Uncle,
Third
niece.
degree, cousins. So second degree, can you explain it on the basis of consanguinity? any heritable disease? Should have presented much
Hereditary.
earlier by now.
Hereditary spastic.
You have done serum B12,
We have sent, sir. We have sent, sir.
sent for it.
Huh.
Though serum B12 is still not a good test because you may have to do the methylmalonic acid, homocysteine, so something beyond that. One wonders whether we have something of that kind, like a subacute combined degeneration, you have upper motor, lower motor neuron combination, but etiology looks a little different and we have no idea whether it's only B12 or so. But the father claims that he is much improved. Now, I don't know what does he mean by improvement. Okay. So, because you feel he is the same.
So nowadays they talk so much about these autoantibody mediated and then multiple sclerosis variants. So where you could get attacks and he could get better and then again come back. So like you said, we don't know whether he has recovered. He may just be lingering and then.
But MS should be more diffused. He is
And
relatively
recurrent.
localized.
But so there is no history of previous attack, no recurrence.
No, this may be first attack.
Typical mitochondrial especially can have waxing and waning, complete recovery and complete again come back with a recurrence. So I think we keep it open all this. But I think this is where you must give us the final progress of such a child. Okay, but then only we are better off. So what have your neurologists talked about?
Sir, they were more in favor of, they were also thinking of some metabolic cause only. So they have advised for MRI brain. They have written as well vitamin B2 with just as what you
And
told.
whatever
Milo.
radiologists put etiology as,
Sir, they have
but
placed.
they said clinically correlate.
How they have mentioned that.
No, but are there any lesions up in the brain?
No, sir, no cortical lesion as such.
Not necessarily cortical, subcortical, or anywhere in the tract.
No, sir. In the C6 till D4, D5, there is hyperintense lesion.
So what really looked like GBS on examination turned out the other way around. Superficially, history-wise, one was more in favor of a polyneuropathy. Started with tingling, numbness, symmetrical, rising, what shall we say, starting from lower limbs, going upwards, no bladder bowel. So what really looked like GBS from the history on examination turned out to be absolutely different. Never expected the pyramidals to be there.
You can send the child. So for the next 10-15 minutes, we can discuss other neurological problems arising out of nutritional issues. Right? So let's start. Tell us, think of any other neurological problem
So we
that.
can start with proteins. Can a protein deficiency, severe of course, okay, mild may have just a little edema, etc., but could a protein deficiency have neurological manifestation? Let's say kwashiorkor, severe protein deficiency. What neurological findings you may get in kwashiorkor? How do you define kwashiorkor? Edema, yes. What else? Of course, you have not seen kwashiorkor, I can imagine that. And we used to see a lot of kwashiorkor. So does it mean that the country has now better protein intake in the population? Is that so? No, it's not so. Earlier, people had a lot of calories but very low protein. So they had what was known as the sugar baby kwashiorkor. Most of these children who had a lot of protein deficiency but enough calories were awarded the first best prize in the healthy competition because they weighed more than others. Okay. Thereafter, now the children don't get even enough calories and don't get enough proteins. But when you take a ratio of calorie and protein, it's not so disproportionate. So we don't say kwashiorkor and we call it PEM. Okay. But does protein cause... So what does kwashiorkor means besides edema?
Just think of your textbook definition of kwashiorkor and say what
Skin
else.
changes, hair changes, and one more, mental changes. So protein deficiency has an encephalopathy. Okay. And how does it present?
What is that word described? What kind of mental change? Apathetic.
Not interested in surrounding, not interested in food. That is apathy. That is encephalopathy, severe protein deficiency. What else could do protein deficiency? Oh, protein deficiency affects every part of the brain. Okay, but minimally. So encephalopathy is shown as a change in behavior, but you may have a myelopathy, a radiculopathy, a neuropathy, or myopathy, or any combination of that. You may get an upper motor neuron science in hypoproteinemia, severe. You may get a lower motor neuron science, any kind of combination. Okay, though we are talking about a severe deficiency. Okay, so that is protein. Would fat deficiency also cause some neurological manifestation? Would carbohydrate deficiency cause neurological manifestations?
Yes, fat deficiency can cause.
Like?
Carbohydrate deficiency doesn't cause neurological thing. Acute hypoglycemia is different. It's not a carbohydrate deficiency. Okay. You may have a muscle weakness, yes, tiredness. That is fine. When it comes to fat, possibly largely the skin, hyperkeratosis, etc. So we move now to vitamins.
Any other connection, not deficiency, but any other connection with neurological manifestations of fats or...
So very long chain fatty acid accumulation and all, like Zellweger.
Metabolic disorders. No, there are so many fatty acid metabolic disorders,
Okay.
carbohydrate metabolic disorders.
So fatty acid metabolic disorders are totally different ball game, not nutritional, but yes. Okay? So that becomes that. What about vitamins?
Yes.
Does vitamin A cause any neurological problems?
Sir, hypervitamin C will cause
Excellent.
pseudomotors.
What a wonderful statement. Not deficiency, but hypervitaminosis. Okay, very good.
Pseudomotor cerebri.
Cerebri.
Okay, then?
B12, B6.
Okay. B6 causes
The convulsion.
all ages,
No, neonatal.
neonatal seizures.
B1,
Very, very.
Niacin.
Niacin deficiency.
folic acid.
See, neurometabolic disorders are known in B complex deficiencies. Biotinidase deficiency, biotin dependent, pyridoxine dependent seizures. So these are all the issues of B complex, and they are treatable metabolic disorders. So we need to look at those little more carefully. Like you said, B12 with subacute combined, but I recall having heard twice in 55 years, that too in an adult, but I haven't had it in a child of that kind. So, but B12 we know that it has a lot of neurological, peripheral neuropathy, etc. Yes. Okay. What about vitamin C?
Irritability and
So now the question is, what is the pathophysiology of irritability in vitamin C? Madam has given you a clue. Is it neurological or is it something else?
Why should vitamin C? Vitamin C is extremely tender, extremely painful. He cannot stand, he cannot walk. If you touch his limbs, he gets pain. Why does he get pain like that?
Collagen. Hemorrhages.
There will be bleed, subperiosteal.
Excellent. Periosteal elevation due to hemorrhage. Okay. Severe pain. And you give vitamin C 500 milligram in 48 hours, the whole story ends that. Okay.
How do
So,
you do the diagnosis? Vitamin C deficiency. Pardon me? What does it show?
There will be subperiosteal hyperintense, and then Wimberger's
Subperiosteal
hemorrhages, and then Wimberger's.
You don't see the
thing.
subperiosteal hemorrhages unless they are calcified.
Wimberger's ring sign.
What is that?
The epiphysis will be surrounded by a ring which is hyperintense, and then
There is in the beginning, there is a generalized, so to say, ground glass appearance with thinning of cortex, and if you come to the epiphysis, there can be epiphyseal spur formation, sometimes fractures, and what is more important is tremors clear zone above the white line of Nilaton. Okay, that tremors clear zone, because you can get white line and anything, and of course subperiosteal will come only after some time. You may see even periosteal hemorrhages in the joints also, but that will take calcification. It will take any blood test.
serum levels are not done. In fact, Buffy coat and all that.
So yeah, so Buffy coat, if at
Oh.
all, if you have ever.
But
done.
there's no need to do that.
Yeah.
Okay, because you have a therapeutic trial now, so even radiology may not be required. Within 48 hours, you have stopped all the symptoms of vitamin C deficiency totally.
And like I
Right?
mentioned last time, the hyperkeratosis, okay, that's a classical sign of vitamin C little older, sir, and I have seen that happen here as well as on the buttocks with small areas of bleeding around.
So that is that, vitamin C. What about vitamin D? Any neurological manifestation? Of course you know. You have seen not rarely.
Come on. Direct, indirect.
Excellent. Child at 1 or 1.5 years of age has one day of fever and then suddenly throws up a seizure because he is already having nutritional rickets and hypocalcemia. Okay. Plus you have all carpopedal spasm and all that, which is neurological. Okay. Which part of neurology is involved in that? Seizure, yes. Okay. But what about carpopedal spasm?
Tetany, neuromuscular junction.
What about myelopathy? Myopathy.
Vitamin D resistant typically. Okay. So is calcium or is phosphate?
So, what is sir talking about? Do you get myopathy in any vitamin D disorders?
Yes, of course, yes. Especially proximal group. And I remember one middle-aged girl came for a proximal muscle group myopathy, and because she was a girl, this was ruled out. She had Wilson's disease, which was hypocalcemic myopathy. And the hypocalcemia at that age was due to Wilson's disease. She was exactly waddling it.
Hypocalcemia affects the muscle, and occasionally, rarely, it can come as an acute myocardial failure. And I'm sure occasionally we have seen this. A 2-month-old, 3-month-old preterm baby, okay, born already, not enough vitamin D there, vitamin D not given, okay, breastfed, fastly growing. At 2 months he is hypocalcemic, vitamin D deficient, and he presents with acute cardiac failure, which is called as myocarditis because we have no other diagnosis. And then you admit him, you treat cardiac failure, meanwhile you send electrolytes. If there is any change in calcium, potassium, etc., you correct, and within next 48 hours he is fine. You observe him for 2-3 days, he is all right. You send him home, and in the next week he comes with again a cardiac failure. One cause of a myocardial failure in a severe rickets is hypocalcemia. And now tell me, when we are discussing that, is it an early rickets or a late rickets that causes hypocalcemia? Early rickets or late rickets? Severe rickets or mild early rickets? It's
Early rickets.
It's always early rickets.
Why?
Why?
In chronic cases, compensation might have taken place and calcium will be normal.
So
How
the
does
parathyroids are already awake when there is a chronic deficiency. So they are ready to pour parathormone and bring calcium from the bone and see that the nerves are neurons are well fed. But in an initial phase, okay, when parathyroids have not got a signal, before that it throws up. So early rickets has a seizure or a myocardial problem, but not well developed rickets. Okay, of course at the end of the story, parathyroid has finished all parathormone, so naturally that will also happen, but not otherwise. So that's vitamin D. Does vitamin E come in neurology?
Ataxia.
Very good. Right? Vitamin K? What happens if a newborn has not got vitamin K? Will he come at 2 months of age or 3 months of age with something?
Hemorrhagic disease of newborn.
Late hemorrhagic disease. Intracranial. So vitamin K can also come. Right? So
Trace
see how-
elements. Trace elements.
Yes.
Manganese.
Pardon me. Magnesium.
Convulsion. Manganese.
Hypocalcemia, similarly hypomagnesia. So when
Potassium.
you treat that, potassium
Muscle weakness.
and lead,
Magnesium,
Pure
potassium.
motor neuropathy.
lead can cause
Lead encephalopathy.
and
So
you
many
don't
of
know
them,
about
right?
strontium and all those things.
Iodine.
Iodine.
Hypothyroidism, right? So many of that. So we just thought that we had so-called B12. We don't know really what's the thing.
We had a feast now.
So you want to say something more about?
I just wanted to talk about 2-3 lines about kwashiorkor.
Yes.
Kwashiorkor, kwashi, orkor. Kwashi means disease of the second one, orkor due to the first one. So disease of the second one due to arrival of the, disease of the first one due to arrival of the second one. What happens? The baby is exclusively breastfed. The weaning does not take place normally, and then when the second baby is arrived, suddenly the baby is weaned and the baby is put, now the second baby is put on breastfeeds and the first baby is acutely weaned. And what was substituted then when it was described in Africa, this baby was put on staple diet. So calorie diet, carbohydrate diet, which gave them calories but completely deprived them of protein. And therefore we got a baby with a relatively good weight but acute deficiency of proteins, which of course doesn't occur now. We now have PEM, protein energy malnutrition, and kwashiorkor is an acute precipitation of protein malnutrition. You treat them, they become protein energy malnutrition, but they may not even recover till you completely correct it. So PEM, K and PM, they keep on changing from one time, but that so-called kwashiorkor is not seen now.
We give massive vitamin D. We give massive vitamin A also. When you see PM, would you give a lot of proteins? Why not? He's deficient. You should give a high protein diet. What can happen? If you see vitamin A, yes, it's an emergency kind of, you will lose the eye. Okay.
Heard of recovery syndrome? Yeah, so when you give high doses of protein, there is imbalance between the protein metabolism and you get what is known as recovery. They are edematous. They may be even anorexic and edematous. This may even occur in a patient who is quickly recovering from diabetes also, but we've seen sometimes when protein energy malnutrition, kwashiorkor is treated with high protein diet.
But it presents like a hypercortisolism. It presents with hypertension, emergency. So that's a recovery syndrome. So there could be also an acute change occurring because of an acute change in electrolytes occurring. And therefore, you need to give slowly. And therefore, PM, you know that when you kind of resuscitate the serious patient of a SAM, then you have, the next thing is about the diet. And what diet do you start for an SAM?
Starter diet, F75.
75 and not 100, because that has just little protein, and then once he starts building up, then you shift up to 100, right?
Okay. How many people in Maharashtra, adults, would be hypocalcemic? Can you guess any number? National Nutrition, NIN, National Institute of Nutrition and National Nutrition Monitoring Bureau, they study the whole country. They say more than 60% Maharashtrians are hypocalcemic. Calcium is less in. I'm very serious about what I'm saying. We just do not know our country. The NFHS 5 says that 60% Indians have, I'm telling you Maharashtra study, but Maharashtra is better than the whole country, better than the average. 60% of us are iron deficient. Then sir said sugar baby. Now we only have sugar adults. Those sugar molecules become fat and are accumulated, as I have. And we should do HbA1c. If it is above 6.5, then the average blood sugar for last 3 months is above 140, which is diabetic. When we eat a lot, we feel drowsy. Is that sugar encephalopathy? We don't study, so we don't know. But I'm sure when you have high sugar levels, you are drowsy, you don't want to work, you want lazy, you sit. To me, it is sugar encephalopathy. So today, every second adult is sugar encephalopathic. Then there is a book, Is It B12? I have a soft copy in my phone. If somebody gives me a number, I'll share. It says, any neurological problem, first think of B12 and give it. And if he improves, celebrate. Thank you.
Also one point, that if you give B12 in a patient who is B12 deficient, it may not really give good results. Not in every case. If you give it orally, because the villi which absorb the vitamin D from the intestine have also atrophied. So though there may be vitamin D in diet, the villi are not capable of absorbing the available vitamin, and therefore you have to give vitamin D parenterally. B12 parenterally. Then the villi regenerate, and later on if you give orally, then they are able to. So that is the position for parenteral vitamin B12.
Fine. I think we'll stop here. So thank you our online friends who are viewing and online faculty. And we stop today's class here. And we meet once again next Thursday 6 p.m.